Welcome to Medicoria. In today's video, we shall discuss angina pectoris. Angina pectoris comes from two Latin words, angias, which means to strangle, and pectus, which means the chest. Crudely, the word angina pectoris translates to strangulation of the chest. Angina pectoris comes from a reduced supply of blood containing oxygen to the heart muscles. Angina pectoris presents with a typical kind of pain. It is usually a sharp stabbing pain which is retrosternal in position. It radiates to the shoulders, sometimes to the neck, to the jaws, and to the back. It may also present in unusual places like the epigastrium, or sometimes it may not actually be pain, but someone may simply experience chest discomfort, a feeling of tightness in the chest, or just feeling that something heavy is sitting on their chest. I also need us to remember that angina pectoris can sometimes be asymptomatic, or it could only present with the atypical symptoms, the entity known as atypical angina. Now, what causes angina? Like I mentioned before, angina is caused by a reduced flow of blood containing oxygen to the heart. But sometimes angina can be caused by an increased demand of oxygen by the heart that exceeds the ability of the coronary arteries to supply the heart with blood containing oxygen. Angina can broadly be categorized into about 4 categories. We have stable angina, unstable angina, principal angina, and microvascular angina. This is sometimes called syndrome X. So let's walk through each of these types of angina bit by bit, step by step, such that we try to break down the pathophysiology and the events that underlie each. The most common cause of angina pectoris is coronary artery disease, particularly the atherosclerotic type. Atherosclerosis is simply abnormal deposition of fat into the lumen of the coronary artery. By far, this is the most common and the most likely that you will experience. But there are other possible causes of coronary artery disease other than atherosclerosis, which I believe we shall cover in a separate video in which we shall talk about coronary artery disease. But for purposes of explaining angina pectoris, we shall focus on atherosclerosis. So as fat deposits are being deposited into the lumen of the coronary artery beneath the endothelia, occlusion starts to happen. Initially, this is asymptomatic because while the occlusion is still mild, the coronary arteries are still able to deliver enough oxygen to our heart muscles. But once the occlusion reaches about 50% of occlusion, if over 50% of the lumen is occluded, the coronary artery is only able to supply blood to the heart while the person is at rest. But once this person begins to engage in physical activity, they experience symptoms of angina pectoris. So this type of angina pectoris, which only presents on exertion but is relieved at rest, is known as stable angina. So here there is pain or discomfort, chest pain or discomfort, or other presentations on exertion. But while this person is at rest, or once the symptoms come and this patient stops to rest, the symptoms are relieved. Now, as occlusion progresses to about 90% of occlusion, this coronary artery becomes even unable to supply blood to the heart even at rest. In other words, the blood supply becomes inadequate, and this patient starts to experience symptoms even before they engage in any physical activity. In that case, it becomes unstable angina, where someone has pain or discomfort even at rest, and this pain is not relieved when the person sits down to rest. Usually, atherosclerosis does not progress to this stage, but what usually happens is that, like I mentioned, this atherosclerotic plaque is usually covered by a layer of endothelium, which covers a lot of molecules that could stimulate thrombosis under here. But as this atherosclerotic plaque is growing, at some point it might rupture. Once our atherosclerotic plaque ruptures, we have molecules, different molecules being exposed under that can activate our platelets, and then we have a clot forming. And then we end up in about 90% of occlusion, which gives us an unstable angina. The third type of angina that I would like to talk about is the principal angina. In principal angina, usually the coronary arteries might be normal, or they might be having disease, but mild disease. But what usually happens here is that you have the coronary arteries constricting due to a spasmic contraction of a small section of the coronary artery, all right? So if this is a normal coronary artery, usually you'd have something like that. And such an artery cannot deliver enough oxygen, enough blood containing oxygen to the heart. The mechanisms that lead to principal angina are not clearly understood, but one of the theories that seems rather convincing is that there is a localized area of the endothelium which is not functioning well. Under normal circumstances, the endothelium produces nitric oxide, which helps to maintain the normal vascular tone by maintaining a bit of vasodilatation. Once you have a section of endothelium being unable to produce enough nitric oxide, that section of the artery, the smooth muscles in that section will constrict, thus narrowing our artery and limiting the delivery of blood to the heart myocytes. Now, so far all the types of angina that we talked about involve what we call the epicardial coronary arteries. The epicardial coronary arteries are those arteries that run in the epicardium. So you have the left and right main coronary arteries that give you the different coronary arteries, the anterior, descending, and so on. So all those coronary arteries that lie in the epicardium are called epicardial coronary arteries, or you can call them the conduction vessels. So usually, all these three types of angina will involve a pathology of the epicardial coronary arteries, and these are the only arteries that we are able to visualize when we do angiography when we are assessing a patient with angina pectoris. However, sometimes a patient may come with signs of angina pectoris. There is actually cardiac ischemia ongoing, but then you do angiography and then your epicardial coronary arteries are normal. They don't have any kind of disease ongoing, any kind of occlusion. In this type of angina, the problem actually lies in the smaller vessels, the arterioles. This type of angina pectoris has some mechanisms which are similar to the ones I've already explained, but it has even others which are different from this. But I think we shall cover this in a separate video. And lastly, let's talk about the other causes of angina pectoris. Like I mentioned in the start, it could be a problem of supply of blood containing oxygen to the heart. But I also mentioned that it could be a problem of an increased oxygen demand by the heart that exceeds the supply that can be achieved by the coronary arteries. Because in a normal heart, whenever oxygen demand increases, there is what we call coronary flow reserve, in that the amount of blood flowing to the heart is increased. So there is a maximum that can be achieved. But once the oxygen demand exceeds the coronary flow reserve, one begins to experience symptoms of angina. So what are some of these things that can increase the oxygen demand of the heart? One is if one has an increased bulk of ventricular muscle. This can happen in conditions like hypertrophic cardiomyopathy. It could be ventricular hypertrophy following things like valvulopathies, a valvulopathy like aortic regurgitation, aortic stenosis, mitral regurgitation, among other conditions. Other things that can also increase afterload, like systemic hypertension, can also increase the oxygen demand of the heart. Sometimes someone could just be, having thyrotoxicosis, because in thyrotoxicosis we have, an increased rate of metabolism, which increases the oxygen demand by the body tissues, which places a lot of stress on the heart to compensate for the oxygen demand. So you have this heart beating so fast, and then its oxygen consumption increases. Sometimes you could also be having, abnormalities within the heart, like tachyarrhythmias, which make the heart to beat abnormally fast, and thus increase its oxygen demand. And once this oxygen demand surpasses the coronary flow reserve, you end up with symptoms of angina. Other causes of angina also include those conditions where the blood has a decreased capacity to carry oxygen to the different tissues. Issues like anemia, all right? If someone has severe anemia, they could also experience symptoms of angina. And then also if someone has systemic hypotension, either due to of a cardiac origin or due to anaphylaxis or due to another cause, even the heart is affected in this situation, and therefore the delivery of oxygen to the heart is reduced, and the person ends up experiencing symptoms of angina. Briefly, that is it. We shall discuss more details in the subsequent videos, but otherwise, thanks so much for watching. Do like, comment, and subscribe to the channel. Don't forget to turn on your notifications so that you don't miss out on the next video. Thank you, and see you next time.